Welcome to the conference session titled Managing PNH and Complications. Thank you for joining us today. My name is Nkirika Ashadu, Program Content Manager, and I will be moderating the presentation today. As we get started, we want to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation. To submit a question or comment, type your question in the Q&A text box window, and when you are finished typing, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do 3 things. Submit your entire question all at the same time. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Srishti Upadhyay. Dr. Upadhyay is a second-year fellow with the Division of Hematology and Oncology at UNMC College of Medicine. Before her fellowship, she completed medical school at BP Koirala Institute of Health Sciences in Dharan, Nepal, and completed a residency at Cook County Health and Hospital Systems in Chicago, Illinois. With that being said, welcome, Dr. Upadhyay.
Thank you, Nikki, for that introduction. So I would say that there are 2 goals in my presentation. One of them is revision of what we have learned from Dr. Nestor and from the question-answer session, and the other is more of recognition of those complications of PNH. Now, let's see how this works. So I am going through the overview one more time, but this is mostly just to make sure that we try to understand this in the most simplistic way possible. As you know, that the name PNH already is in a very, it's a very sophisticated name for a very rare blood disease, but we are going to try to understand it in the most simplest way possible. So we know by now it is a disease where our red blood cells tend to break apart. We give it a fancy term, which is called hemolysis. When these cells break, they spill a protein called hemoglobin, and that gets spilled inside our blood. And most of the PNH symptoms is basically from the release of that protein hemoglobin. We all know there are 3 types of blood cells. Just a revision, there are red cells, there are white cells, and there are platelets. Red cells is the one that occupies most of the blood. It has that protein hemoglobin, which basically what it does is it carries oxygen in different parts of your body. White cells is the one that helps you fight infections. It attacks the germ cells that get into your body. And platelets are those cells that kind of form plugs in your blood cells, blood vessels basically, so help prevent blood clots. So blood cells are formed inside this reservoir or this factory called bone marrow. It is a spongy tissue. It is located inside your certain bones. What it does is it has the stem cells called the mother cells that makes the 3 copies of the different types of the blood cells. These cells then float around in your blood in the bloodstream. How does PNH happen in our body? Well, what happens is somehow you acquire a genetic mutation in one of the gene of that single stem cell in your bone marrow, which is the mother cell. So now the stem cell multiplies into identical copies or clones of itself, and this stem cells then matures into making abnormal red cells. The term clone is basically the term given to all those abnormal red blood cells that can be seen in a person with PNH. Understanding the complement system and the mutation. So how this PIG-A gene basically works in your body is it forms kind of that protective shield on the surface of your red cells to protect it from destruction by complement system. Complements are actually a good thing for your body. They rotate in your bloodstream and they support the work of white blood cells by fighting infections. However, when you have a PNH red blood cells, remember those are the abnormal red blood cells, which have no protective shield on their surface. Now they're open to attack by complements at all times, at good times and at times when it's not necessary. So this leads to a chronic state of hemolysis, which is the state where your red cells are just basically breaking down. This gets exacerbated in situations of stress, such as surgery, trauma, or other triggers of inflammation. So on the left, I have the normal RBC, which basically has that protective shield to get protected from the floating complements in your blood. What happens to a PNH RBC? It basically loses the helmet, so it is basically prone to destruction by the floating complements. So the course and impact can vary. Some people can be lucky, maybe asymptomatic. Some people can get mild symptoms, and some people might be at the point where they need medications, blood transfusions. They can develop blood clots in key parts of their body, and they might eventually have other complications from the associated bone marrow failure. With the significant research that has been happening in the field of PNH, the life expectancy has dramatically improved over the past 20 years. So now what is bone marrow failure? I think by now we already know. So basically the simple definition of bone marrow failure for me is that your body is just not able to supply you with the blood that it needs. In other terms, it's basically not able to produce enough blood cells, or the blood cells that are produced are very damaged or defective. Most patients with PNH have some degree of bone marrow dysfunction. And this can range from, like we talked about, mild, asymptomatic, low blood counts, not really bothering you. They're just low, but not doing anything to you. But can also range to severe bone marrow dysfunction that can lead to recurrent infections and other complications such as bleeding, bruising. So summary, it is a rare disorder. It is acquired. It's not an inherited disorder. And it is a disorder of your mother cells in the bone marrow, that is the hematopoietic stem cells. And it has three main components to it. One is the hemolysis, that is the breaking apart of your RBCs. Another is bone marrow failure, in which you just don't have enough blood cells in your body. And another is thrombosis, which is basically you're prone to get more blood clots. So that was the basic overview. The topic that was assigned to me was mostly complications of PNH. We know that it is a rare condition, but it has a significant impact on the quality of life of a patient. The diagnosis is complicated, and the treatment options requires a well-trained and experienced expert. I would think that a lot of complications of PNH that we used to see in the past is also because the recognition was so late. So really the gist of my presentation today is to know what are the complications and what are the things that we should be educating each other on in terms of diagnosis such as PNH. So thrombosis. Basically what this term means is blood clots. How often it happens? In 40% of people with PNH during their lifetime. It is a cause of significant morbidity. In fact, the most important cause of morbidity burden in people with PNH. These clots tend to form more in those venous system than in the arterial system. They tend to, like Dr. Nestor said earlier, they tend to occur more in the uncommon spots, such as in the blood vessels in your brain and the blood vessels in your belly. The more common spots being the blood vessels in your legs or your, arms or your lungs. Hepatic vein is in fact, hepatic means liver. Hepatic vein is in fact the most common site of clots for people with PNH. So how do we manage a blood clot? Basically, your blood is clotting because it's getting thicker. So how we treat it is by making it thinner with the help of an anticoagulant. I'm sure you guys have heard of medications such as apixaban, rivaroxaban. However, in people with PNH who develop blood clots, just the treatment of blood clot is not enough. It's for people who get those clots is when we add those complement inhibitors that we discussed earlier. The main idea about adding those complement inhibitors is to prevent the further recurrence of these blood clots. What is the duration of anticoagulation? If your disease is well controlled with a complement inhibitor, and if you do not have any other clot predisposing factors, you could use it for a specific duration, 3 to 6 months. You don't have to use this lifelong. But this question of duration is really individual dependent, and I think it depends upon a lot of other predisposing factors and comorbidities. One of the complications that I want everybody to recognize is Budd-Chiari syndrome. It is basically a fancy term given to the blood clot happening in hepatic vein. What happens is when your hepatic vein gets clotted, the blood just backs up into the liver, and as a result, your liver tends to grow larger. It has variable presentation. Some people might not have all of the vein obstructed and might not even feel it. Some people might present with acute liver failure because a lot of blood is congested. And some people might accumulate that over the course of years and develop what we call chronic liver failure or cirrhosis. Oftentimes, an alarming symptom is when you get sudden onset abdominal pain or when you develop sudden distension in your belly. If you notice any yellowing of your eyes, which we call jaundice, like the picture of that gentleman in the image, that's certainly an alarming symptom. The treatment for this is definitely we would think about treating with the complement inhibitors for the PNH, but Budd-Chiari syndrome might need additional measures, especially in the beginning, to relieve that pressure. So it might need some shunts between your hepatic and systemic circulation. And in severe cases, it might even need a liver transplantation. Also, blood thinners would be another treatment. So we talk so much about blood clots. What about the role of using blood thinner to prevent blood clots once you are diagnosed with PNH? We actually suggest not treating with prophylactic anticoagulation. In other words, not using blood thinner to prevent blood clots in somebody who has never had a blood clot before. Why we do this? This is based on a high quality evidence that says that there's no guarantee that this effectively prevents blood clots. The exception could be pregnant women. We may start a blood thinner at around the last trimester and continue treatment for up to 8 to 12 weeks postpartum in women that are pregnant to avoid pregnancy-associated complications due to their coexisting PNH. Certainly, some things that I want everybody to know is, sure, you have PNH, you have increased risk of blood clots because of the disease itself, but there are other things that could increase your risk to get blood clots. And these are possible other things where we can focus so that we can reduce the total risk. Cigarette smoking, diabetes, at least, targeting towards having a better control of your metabolic syndrome. Obesity, women that use estrogen progesterone compounds, especially those estrogen compounds or the oral contraceptive pills, those are at higher risk of getting blood clots if they also have PNH. Pregnancy is an additional risk factor for having additional blood clots if you have a PNH. Surgery is a stress situation, and that can increase your chance of blood clots. Prolonged immobilization, if you're not moving around basically for a week or so, that certainly increases your risk to clot a lot more. Now moving towards a little bit of shifting gears towards symptoms related to hemolysis themselves. So like we discussed, hemolysis is basically your red cells breaking apart. They can cause fatigue because you have low level of hemoglobin in your body. You can feel short of breath. You might need repeated transfusions to get to a functional level. You might notice episodic pink urine or cola-colored urine because you're basically losing that hemoglobin in your urine. You might get some pain, and I will explain later why you get pain. And you might actually get symptoms of organ dysfunction because you really have low hemoglobin. And like I explained earlier, hemoglobin is the protein that carries oxygen in your body. How do we manage this? Basically, I heard we had a lot of questions in the question and answer session that kind of focused on when we start treatment for PNH. And I would say this is also one of the indication. So basically, this, because now we have this complement inhibitors, we can say that rather than just doing supportive care such as transfusions, this is an area where we start thinking about starting a complement inhibitor. These have been shown effective for symptom relief, and like I said before, prevention of blood clots. And if you really think about it, they do not have a lot of toxicities in general. This research, I think, was very interesting. What they did was they took a group of patients and they asked the group of patients with PNH. This is the data just in people with PNH, and they asked what are the strategies that you have found helpful in terms of fatigue management. They rated the strategies that were rated 3 to 5 are listed here. So preserving energy, which basically means preserving it for the time of the day when you need to do the chunk of work. The other is physical activity. So apparently staying active helps fight the ability to not do anything, or helps fight the ability to stay not feel that drained, I guess. And taking naps in between is probably another strategy that helps. A timely diagnosis and subsequent treatment inhibition with those complement inhibitors can prevent the disease from worsening to an intolerable degree. And believe it or not, these days when we talk about, fatigue with PNH, it might seem a little outdated, but before, when diagnosis used to take a very long time, fatigue was the most common bothering and intolerable symptom for a lot of people. I think the other way which we as physicians can improve is we can use surveys quantifying quality of life regularly during our consultations. This will allow physicians to ask the pertinent questions in the orderly manner, and I think this kind of opens up the space for honest dialogue and careful follow-up. Shifting gears to anemia. Basically, this is the condition where you have the low hemoglobin. That's the protein inside the RBCs. In PNH, you can have anemia from a lot of different mechanisms. So one of them is basically stemming towards why PNH happens. Red cells break down. So that's why you can have anemia. The other etiology is you can have a bone marrow failure. The other thing is because your body is trying to compensate for the red cells that are lost, you might actually have deficiency of other nutritional agents that is required to make red blood cells. For example, folate or vitamin B12 deficiency. And when you lose that hemoglobin, the red cell pigment in urine, you can actually also lose iron, which is very important to make red blood cells. The treatment for this is you might need transfusions until you start your complement inhibitors. You might need to take folate supplementation. In fact, we recommend for people who tend to break their RBCs regularly, we recommend them to take folate almost every day in order to account for the increased demands due to ongoing hemolysis. And if you are deficient in iron, you might as well take that iron supplementation. But be mindful to not take the iron supplementation if you are not known to be iron deficient otherwise, because all the transfusions that you are getting actually also increases the levels of iron in your blood. So pain control. Chronic pain is in fact a problem in people with PNH, and this can in fact persist despite treatment with complement inhibitor. I have to say, even as physicians, sometimes this is the most hardest symptom to take care of. I would, for pain management, I always like to think about it with as true therapeutic strategies, pharmacologic and non-pharmacologic strategies. Some examples of non-pharmacologic strategies could be exercise, actually group therapies, aquatherapies, yoga, and walking is my all-time favorite. Physical therapy. I think physical therapy helps you sometimes get more motivated and teaches you the stretching techniques, which might just be enough for those annoying pain management. Sleep hygiene techniques, behavioral techniques, focusing on health and lifestyle interventions, and acupuncture may be other helpful modalities that we can think about. The other thing that we discussed earlier, infectious complications, can happen with PNH. Could be because of two reasons. One of them is because your marrow is failing, so you don't have enough white cells to protect yourself from infections, or because of the therapies that you use, the complement inhibitors. We learned earlier that we have to get those meningitis vaccinations. That's kind of mandatory before you start the eculizumab for this reason. We also learned earlier that we have to take those anti-Haemophilus influenza B vaccines. What I also want to additionally recommend is take your pneumonia vaccines. Streptococcus pneumoniae is the organism responsible for that. A little bit more about other symptoms and complications. I think this was one of the questions in the previous session. Yes, PNH can lead to acute or chronic kidney disease in some individuals. It can lead to pulmonary hypertension, which is basically increased, it's because of the blood vessel constricting in your lungs. It can sometimes lead to erectile dysfunction. People can have difficulty swallowing. People can have sudden pains. The pain can be in their belly or in different parts of their muscles. Really, the reason why people get pain and episodic pains in PNH is when your red cells tend to break, they release that hemoglobin. When that happens, your blood vessels tend to undergo spasm, kind of like a constriction, and that disrupts the natural tone of the muscles and hence leads to the pain. Special precautions that we could take when we are going on long flights or rides. Remember that we are at risk of blood clots, so get up and walk around every hour or two, if it is safe to do, of course. High altitudes, consult your doctor. So I think there was one of the questions about this. So I would say there's no specific thing that we should do before we travel, but let's say if you are very anemic, then your oxygen carrying capacity is low. So that would be a thing that you need to tell your doctor so that you can get a blood transfusion before you go to high altitudes. Pregnancy, I would really recommend any female patient who is getting pregnant and has PNH to look for a PNH specialist, and have an obstetrician who specializes in those high-risk pregnancies. Remember that you have few healthy bone marrow and few blood cells. You have more chances to clot than other pregnant women. You might need more transfusions, and you might have increased risk of one of those pregnancy-related complications called preeclampsia. There are some complications in the baby as well, which, however, with the treatment options that we have available these days, tend to be less, but it's really important to recognize. Surgery, like we discussed, you can have increased complications due to increased hemolysis, your blood counts are low, and you are at increased risk of clotting. So it's really important to, I think, number one, to recognize what are the situations that we should be careful in, and to involve your PNH specialist and your surgeon versus your obstetrician in your care. Thank you.
Thank you, Dr. Upadhyay, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. So we're going to go ahead and ask some questions. So the first question is, since PNH occurs at night, or the majority at night, is there any relation with sleep/insomnia?
That's a great question, but I don't know if I would say PNH occurs at night. I think it's more of a misnomer that comes from the name itself, and that's what we knew in the past. The reason we used to say PNH happens more at night is because people used to see those dark-colored urine or the cola-colored urine getting passed more in the night, because simply your urine is more concentrated at nights. In fact, your hemolysis should actually happen at all times of the day if you are somebody who tend to have broken red cells. But I would say the disease, the symptoms of the disease, for example, the fatigue, and the pains might be more felt at night. So that could lead to, sleep disturbances. But I wouldn't say that night is the time when you get more hemolysis.
Thank you. Our next question is, can PNH be cured? How long are you able to stay on Ultomiris? What is the life expectancy?
So the answer to cure so far is unfortunately no. What we know is we have some agents to kind of modify the complement, basically confuse the complements. But what we have not been able to do is modify those abnormal stem cells or the mother cells in the bone marrow. Once you start treatments such as revolutimab or the Ultomiris, you kind of have to stick to it lifelong, because at this point we do not have any strategies that can, like we say, cure the disease by itself, unless you need bone marrow, you get a bone marrow transplantation.
Thank you. And our next question is, what triggers PNH?
That's a great question. It is, you mean the trigger for, sorry, I have a follow-up question to that. Do you mean what triggers the disease, or do you mean the symptoms?
Symptoms.
Okay. So I would say that for most people, the things that trigger the symptoms of PNH are any kind of stress situations, any kind of stress to your body or to your mind. So it could be infections, it could be travels, it could be surgery, it could be, in fact, any kind of trauma, and that could be a mental or physical trauma.
Thank you. And the next question is, I am a PNH patient and have low platelets despite doing well on drug therapy. Are low platelets a complication of PNH? If so, how should this be addressed?
Yes, low platelet is a complication of PNH. A subset of people with PNH can have associated bone marrow failure, like we discussed, and it could be, there's a chance that the low platelets that you have is from PNH. Certainly, I would say that the first step would actually I don't know how low your platelets are, but it would require the workup to see that you do not have any other disorders, because low platelets can happen because of many other bone marrow related conditions or even peripheral blood related conditions. So I would say, number one, that would be the first thing to find out what is the reason you have low platelets. And if you have low platelets because of your PNH, certainly the treatment would be to do medication therapies such as platelet factor supports, and it really depends upon your conversation with your blood doctor and the level of your platelets. But those are the certain group of peoples which might ultimately have discussion up to a transplant strategy.
Thank you. Our next question is, how do you determine what are complications of the disease or side effects of therapy?
Sorry, can you repeat the question again?
How do you determine what are complications of the disease or side effects of therapy?
That's actually a great question. I would say PNH therapies do not have a lot of toxicities. The toxicity profile is really modest. So really, the one of the most important risk associated with the therapy is infection risk. In fact, even the fatigue that you see with the disease itself improves with the therapies. So a lot of symptoms that you might be experiencing could actually be because of the disease itself. And there's this entity called breakthrough hemolysis that happens when you are still on treatment. So, a lot of it is probably more disease related than therapy related.
Thank you. Our next question is, what complications would a patient experience if they were to stop using treatment?
Basically, the complications would be the same as what are the complications of PNH itself. If we are not on the treatment, the complement system is active again, and it starts doing the same job it used to do before.
Thank you. Our next question is, my sister has been diagnosed with PNH and now suffers from brain fog. How can we help her? Is this permanent? She is talking about stopping therapy as she thinks therapy is the cause. Does PNH as a disease cause brain therapy? Or brain fog? Does PNH as a disease cause brain fog?
So I think this is a very this is a very great question, and when I was preparing for the talk, I did see some mention of a lot of non-specific symptoms, which we often tend to ignore, such as fatigue, such as not feeling the best, and I didn't particularly see brain fog. I have to be honest, but and I don't actually know if it's because of the disease versus the therapy, but I would say that for people with such symptoms, I would really focus on that slide that I showed about the strategies that could help you overcome. For example, taking naps in between, really focusing on physical activity, group therapies, and I would say platforms like this, like talking about this with your physicians, talking about this with your other friends who have same disease, is probably one of the strategy that can help.
Thank you so much. And does anybody have any questions in the room? Okay.
Maybe not so much a question. maybe not so much not so much, is it on? Yeah. Maybe not so much a question, but one of the earlier questions was, what is the survival rate? And generally speaking, 30 years ago, I was told I would be on hormones for the rest of my life. Let's not, my PNH went away in about 8 years. Let's not ignore spontaneous remission or miracles. So do not, if you've been diagnosed or your sister's been diagnosed or whatever, don't lose hope and don't think, well, you know, I'm going to have this thing forever, because maybe you will, but there are cases like myself where you don't have it anymore, and that was 30 years ago.
That's a great point, and thank you for bringing it. Just because we don't know doesn't mean something does not happen. Thank you so much.
Thank you so much. Thank you so much, Dr. Upadhyay, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. 1, send an email to help@aamds.org. 2, call the AAMDSIF helpline at 800-747-2820. And 3, submit a question on our Facebook page, www.facebook.com/AAMDS. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with our conference sponsors. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes the session.